Good afternoon, everyone. Thank you for joining us in the sponsored session. This is sponsored by ATC and NEPRO. Today we'll be talking about NIRS-guided PCI, beyond calcium and precision to PCI. So we'll be discussing the objectives, and I'll be introducing my friends and colleagues for this session. So can we please have the slides? Okay, so the discussion is See Beyond, strategic shift enabled by NIRS. So in terms of learning objectives, what we're going to be talking about today is to identify vulnerable plaque. NIRS detects lipid-rich plaque that are invisible to angiograph. This allows interventionalists to anticipate complications like distal embolization or no reflow and adjust their approach accordingly. And to optimize lesion preparation, NIRS reveals high-burden plaque or calcified nodules, and it allows operators to choose between atherectomy, intravascular lithotripsy, specialized balloon to modify the lesion before stenting it. It also will help with improved stent placement and expansion. So with NIRS IVUS guidance ensures that the stents are deployed in a stable segment, avoiding lipid-rich or heavily calcified area that might compromise expansion or healing. I'll be introducing my colleagues. Dr. Mohammed Al-Haji is the director of the Structural Heart Program in Qatar. Dr. Ahmed Kabashi is interventional cardiologist at Qasimi Hospital, and Dr. Thomas Rolda is the medical faculty at Warsaw University of Science and Technology. So we'll go ahead, and Dr. Ahmed will be starting with his case presentation.
Bismillah ar-Rahman ar-Rahim. Dear colleagues, Mr. Chairman, thank you so much for involving me in this very elegant session. I would start my presentation. So the presentation about the plaque vulnerability, and actually the technology that we are dealing with today makes detection of plaque vulnerability is made easy. And these are my potential conflict of interest, but the main disclosure that I would like to declare that I have an enduring and deep belief that angiography is not enough. So any technology that gives you an extra and added information and value to the angiography that you use every day is very welcome in our armamentarium in fighting atherosclerosis. The vulnerable plaques, as you all know, starts from developing very early into fatty streaks, and then you have this lipid accumulation in the arterial wall, and then developing into a lumen occlusion type of plaques that finally ends up with all the ACS that we deal with every day. That's why we need to detect the plaque at its most weak part, at its most vulnerable part. It gives you some signs that the plaque is about to cause a problem, and these signs have been extensively studied in many of the technologies that we have. If you use IVUS, you can detect a vulnerable plaque if they have a plaque burden of more than 70%, and if the minimal lumen area at the site of the lesion is less than 4 millimeters square. By OCT, you need to measure the thin cap of the plaque, and if it is below 55 or 60 microns, this is a vulnerable plaque. But the technology that we are dealing with today makes it very easy. It's only two colors, white and red. If you have a lot of white, this means that you have a lot of lipids. This means that this plaque is vulnerable. So it takes a lot of effort and a lot of knowledge for you to detect the vulnerability of the plaque, as we will see here. I will demonstrate this with one of my patients. I saw her like in August 2024. She's a lady, 71 years old. She is morbidly obese, of course hypertensive, diabetic on oral therapy, a little bit of uncontrolled hemoglobin A1C SEC3, and her LDL at that time was 2.4 millimole per liter. She experienced a TIA before the presentation, as well as a previous knee surgery. At that time, she complained of mostly cardiac chest pain, CCS class 2, and a little bit of dyspnea. ECG was uneventful, and at that time we were carrying out a program for FFR CT, and we did here a multi-slice CT, and applying the FFR technology to the CT, it proved to have an insignificant lesion in the proximal LAD, and other non-significant lesions and irregularities as well in the other vessels. But because she had a sort of a typical chest pain, although not that severe, we subjected her to invasive coronary angiography. And as you can see here, it confirmed what the CT from the structural point have eluted, and a borderline lesion in the proximal LAD, a very mild lesion in the mid LCX. And because we are running a study on diabetic patients, controlled versus non-controlled, with the near-infrared spectroscopy, also we repeated the FFR inside the cath lab invasively, and she had also a negative FFR and a little bit high IMR, denoting mild microcirculatory disease. So we just tried to see what the plaques inside the coronary arteries looks like in terms of lipid content of the plaques. And this is for her right coronary, and as you can see, a very little small area in the mid part here that is appreciated angiographically, a little red area in the mid part of the LAD. The plaque burden is not that severe, certainly below 50%. So in the mid LAD, she didn't show the classic signs of vulnerability that we just mentioned. But if we go to the LAD, also concentrating on the proximal segment of the LAD, as you can see here, a lot of yellow. This denotes a highly vulnerable plaque. The lipid core plaque index at this particular segment was 576. And as we mentioned in the studies, the cutoff level is 325. So this speaks about a very vulnerable plaque in the proximal LAD, albeit the size of the lumen is not obstructive. And the plaque burden measured at this particular segment was also denoting a sign of vulnerability at 64%. So now we are dealing with a angiographically, physiologically insignificant with a high lipid core and signs of plaque vulnerability. So I stop for a moment and ask my colleagues, what would you do for this patient at that time?
Great case, Ahmed. So I'll open the discussion for the panelists and then the audience. So, Mohammed, what do you think? What would be your practice today in regards to this patient?
I mean, this is a very great case, as you've shown that the LAD is a vulnerable plaque, and there is a trial that showed potential effect of revascularization in this group, the PREVENT trial, to reduce the future risk of revascularization and events. But we really don't have additional data in terms of further modification of medical therapy, like how much intensive do we need to be in terms of medical therapy. That's also another way to look at it, because we know that medical therapies, like in PCSK9, for example, and NIRS studies, a lot of NIRS studies were done in those groups, have shown regression in lipid core burden index. So it's very hard to determine the best way to treat, because you couldn't define by FFR significance here. So I would aim toward more of intensifying medical therapy at this stage.
Thank you, Mohammed. So we have two studies, one showing by FFR that if you leave a FFR negative vessel, that it's the outcomes are good for 5 years. And then we have the PREVENT trial that tells you to stent a maybe FFR negative vessel, but is a high vulnerable plaque. What do you think, Thomas? What would you do here?
I think we are right now at the edge what to actually do with it. I think some of those lesions we're gonna have to treat aggressively by PCI-1 inhibitors probably. On the other hand, there will be cases where we should stent it. There are some other techniques tested, like DCB for vulnerable plaques or even bioabsorbable scaffolds. I mean, I think what was shown really nice in this case, that NIRS is the very easy way to detect vulnerable plaque. But from the IVUS, we may get more measurements and actually see which plaques can be smaller in the future, or those which cannot. CT data shows that if plaque reach a recent plaque volume, you cannot make it smaller by pharmacotherapy. So I think we are at very good age what to do with those cases.
So what about the audience? What do you think? Should we intensify medical therapy or go ahead and stent? Any takers from the audience?
So if we have a show of hands, who would stent this vulnerable plaque in the proximal LED? So who would go for intensification of the medical therapy? And yeah, perfect. So
I think medical therapy is underutilized. If we even look at our ACS patients and how many of them at 6 months or a year after their ACS have reached LDL targets, we have very powerful agents now, PCSK9, inclisiran, that can really, combined with statins, get us to target. And as Dr. Hedges pointed out, there are very good imaging-guided studies have shown that aggressive lipid lowering tends to stabilize these plaques, thickens the fibrous plaques, reduces the lipid pool. So really, we have a long way to go. If we were to aggressively treat our patients, the ones that even come to us with ACS, and reach those targets, we'll go a long way to eliminating many of those vulnerable plaques without having to really look for them and decide to treat them percutaneously.
yeah, exactly. And this is actually, we did, as you all mentioned, we intensified the medical therapy. We put the patient on PCSK9 inhibitors. And I saw her like some months later with the diabetes well controlled on hemoglobin A1C of 5.5. Dyslipidemia, we brought her LDL down to 1.4. And she actually lost some weight, 7 or 8 kilograms of her weight. And now the body mass index a little bit better. But she presented this time with a typical classic anginal chest pain with exertion dating 4 months before she presented to my clinic again. And at that time, I couldn't find any reason not to do an invasive coronary angiography. And here, what we found, the right coronary was the same, so no changes in the mid-RCA part, but the LED was totally occluded, exactly at the same location of the vulnerable plaque that we detected the high lipid core index. Again, from the ariocaudal, the PA cranial, and as you can see here, the stump in the LED just speaking about total occlusion there. At that time, of course, we went ahead with do PCI to the LED. We stented the proximal LED with 2 bioabsorbable magnesium-based scaffold, and the patient is doing fine so far. So, ladies and gentlemen, my take-home message is that with the usage of the very nice and very high-resolution IVUS, in addition to the near-infrared spectroscopy, your detection of plaque vulnerability is now democratized. Everybody can detect a vulnerable plaque, not only those who are very deep into OCT measurements of IVUS. It's only a matter of yellow and red, and then you can detect the vulnerable plaque. And then we have to see what we are going to do with the vulnerable plaque that we are detecting at that time. Thank you so much. And please remember to put on your glasses. Every added technology in the cath lab that you see better, know better, is a piece of glasses that enables you to see better. Thank you so much for your listening.
Thank you, Dr. Ahmed. I think this case represents the power of NIRS, right? So you had a patient that had vulnerable plaque. You optimized medical therapy, and yet still this patient came out with an outcome of a CTO of the LAD that required PCI down. So maybe this could have been prevented 10 months prior to her event. What do you think, Mohammed?
Yeah, I think very, powerful message about the role of detecting vulnerable plaques, and I think NIRS is probably the best technology to detect lipids. And I think integrating NIRS with IVUS will help really identify those patients. I still don't know how to deal with those in terms of revascularization versus if they do not have any physiological evidence of, let's say, significant compromise in flow versus intensifying medical therapy. I think in the future we'll know better once we, potentially randomize those patients to intensive medical therapy versus PCI and see which one actually do better for those patients.
Great, thank you. So Dr. Thomas can be presenting his second case now.
Great, thank you very much for invitation. It's a real pleasure to present some ideas here. These are my potential conflicts of interest. So for those who are not familiar with technologies, I want to present just a short glimpse what NIRS is and what it presents. So it's a very simple analysis. You get a NIRS map, it's a 7-digit map. When on the x-axis you have the length of the pullback, on the y-axis you have a circumference of the vessel which is open in the grease. And on the map you have a yellow spots and red spots. Yellow means that you have a lipid, red that you don't have a lipid, and that's it. Out of this map you can get the LCBI index, which is lipid core burden index. It's the number of all yellow pixels and the number of all pixels divided by the number of all pixels in the selected segment and multiplied by 1000. So for example, in this segment, which is around 30 millimeters, you have a LCBI 260. But if you squeeze it to the 4 millimeters, you can estimate that in 4 millimeters, the maximal LCBI in whole segment was 570. Why this 4 millimeter is very important? So as was shown on the previous presentation, it helps us to detect vulnerable plaques. If we have it more than 400, it's based on LRP study. And with the modern technology, it was implemented and overlay on IVUS, HD IVUS. So it gives us a new opportunity to analyze images, which we usually had only for IVUS, but which is very limited to detect lipids. With the spectroscopy, you easily can detect lipids with IVUS. And as it was said, it was invented for detect lipids, but I found it quite interesting to guide current calcified lesion stenting. So, as we know, angiography only reveals 30% of calcification which we have. We have to use intravascular imaging to guide our stenting, our PCIs, especially to detect calcification. And as we know, calcification is the worst thing to deal with in a cath lab. We right now have a optical coherence tomography and IVUS. From the OCT, you can detect heavy calcified lesion by measuring the thickness of the calcium, by measuring the calcium arc, and the length of the calcium. If the thickness is more than 500 microns, if the calcium arc is more than 180 and the length is more than 5 millimeters, we say that we have a heavy calcified lesions. On IVUS, we cannot measure the thickness of the calcium, but we can measure the calcium arc and the length. And in IVUS, if the calcium length is more than 270, we have a heavy calcified lesion. But how NIRS added to it? As you can see, we have two calcified lesions on the histopathology. On IVUS, both almost look the same as calcified lesions, but on the one, we can see the lipids on the top of the calcium. On the other one, we don't see it. So we can distinguish between two different features here. Also, if you take a look at this IVUS image, which shows almost heavy calcified lesion, we can also detect lipids behind the calcification, so it may change the way we can modify the plaque. Also, what I found quite interesting, that you can detect calcification nodule by IVUS, but by NIRS IVUS, you can have a heavy calcified nodule, the one which is sticking out to the vessel, with no lipids behind, but also you can have the other calcified nodule, which also sticking to the vessel lumen, looks the same on IVUS, but behind you have a lipids, which may suggest that it's an eruptive calcified nodule, which is also completely different morphology and much easier to modify. That's the case of the 37-year-old man who was admitted to my cath lab with STMI of inferior wall. This was his right coronary artery, and in the NIRS, what you can appreciate is calcification sticking to the lumen, so calcification nodule with lipids behind. And it was very easy procedure. I used just non-compliant balloon stenting. It was really done very fast and very easy. I didn't need to use any advanced techniques. So how NIRS can modify IVUS calcification assessment? This is heavy calcified lesion on IVUS. Normally, you just measure the calcium arc, which right now is 312. If it's 5 millimeters long, you may say that this is a heavy calcified lesion. But if you add a NIRS on top of that, then you see that you have it behind the heavy calcified lesion, and you may measure the lipid arc behind it. And if you take out this lipid arc from the calcium arc, the final arc, calcium arc is 224. So it's no longer a heavy calcified lesion because it's less than 270. So it changed the way we perceive calcification. We did some initial measurements, and in 70 measurements of calcium arc, 66% of them had the lipids behind. 11, when we take the lipids out of the calcium, was 0, so they were all lipid-rich lesions. And when we compared those measurements, the original calcium arc versus those modified by lipid arc, we have a significant changes in the way we perceive the plaque. So it really makes a difference when you use NIRS to detect and classify calcified lesions. That's the case of a heavy calcification patient, which was a heavy calcified LAD, which was detected by CT. As you can appreciate on the images, 1,244 Hansfield units. It has a length 29 and a calcium arc 246 based on the CT. That was the patient's angio. You can see some calcium in the mid of LAD. And this is patient's IVUS. And what you can see, you see calcification on IVUS image, but behind we have a lipid-rich plaques with max LCBI 378. So when we saw CT, we were preparing for an advanced case. But at the end, when we compared that, we had final arc 177, although if we took it only for IVUS, it would be 280. Comparing to the CT scan, also quite less. And we did a very simple procedure, just non-compliant balloon, 2 stents with a good angiographic results, with a proper stent expansion. So it makes the planning for procedure completely different. So how also NIRS IVUS can predict procedural MI for calcified lesions? So Eri et al. In 23rd presented that we have 3 major predictors of periprocedural MI which you can take out of the NIRS IVUS. One is the evolucent plaque, and which you can appreciate it's here the hole in the vessel wall which shows the plaque. It calls evolucent plaque, and the lipid behind. You may have attenuated plaque where you just don't have attenuated signal in the plaque with lipids behind. And the third predictor, if you have a lipid-rich plaque detected by LCBI, when the LCBI in 4 millimeters is more than 457. So if you have just a lipid-rich plaque, you have prediction at level of 30% that you're gonna have a periprocedural MI. If you have those 2 distinguished features like lipid-rich plus evolucent or attenuated plaque, the probability is 47. But if you have a presence of all of those 3 features in the plaque, you may expect in 80% there's gonna be some distal embolization during the PCI. Here is the case of a calcified LAD. You can appreciate it in the mid-LAD. We tried to image that with NIRS IVUS, but the catheter didn't went through. It was too tight. But anyway, we did this initial run. At the entrance of the lesion, we could see the heavy calcified lesion, but above we could see a lipid-rich lesion with LCBI in 4 millimeters, 633. So we performed rotablation because we couldn't cross with anything for this lesion. And after the rotablation, what you can see, we had a slow flow, probably from this lipid plug above, which was present. So we did our IVUS again, NIRS-IVUS again, and in the stitis area, we had a good plaque modification, but the lipid was still present above the rotablated plaque. Then we just did a simple predilatation, test implantation, we optimized it, and after the stenting, we received a good flow, but what you can appreciate on the NIRS image that all the lipid is gone. From the 633, we have LCBI 184. And what we have detected, it was elevated troponins after the procedure, and we had a 4A myocardial infarction, so periprocedural infraction. Why we can conclude that after stenting, we don't have a lipid anymore? Because if you look at the histopathological data, that's freshly implanted stent in the histopathology, and NIRS shows still lipid behind it. So if it's not present, it's not there like on the image on the right side. So we may conclude that all the lipid was gone and caused periprocedural myocardial infarction. Final case which I wanted to show is to how NIRS and IVUS can help us with intravascular lithotripsy. Just a short reminder that this ultrasound lithotripsy makes a cracks in the calcification. These are histopathological images, and this is what we are looking for when we do intravascular imaging to find whether we have a cracks in calcification when we did intravascular lithotripsy. That's the case of the calcified LAD. We did a predilatation with non-compliant balloon, but we could not achieve a proper lesion expansion. So we performed NIRS, and what we found that it was a calcified plaque with some lipid LCBI 4 millimeters 2001. Proximally, it was a heavy calcified lesion, so we decided to go with intravascular lithotripsy. We did it. This is how it looks post-IVL, and post-IVL showed a cracks in the IVUS, which was very well presented in this HD IVUS. As well, what was quite interesting, the max LCBI in this segment rose from 201 to 310. So probably the cracked calcium revealed the lipid behind the plaque. So somehow NIRS also may help to guide you whether you did a proper lithotripsy application. Post-stenting with a good results was achieved very easily in this case. And this is how it looked like in the NIRS-IVUS with a proper stent expansion in the calcified as well as the lipid-rich lesions, which still stayed behind. So I would like to propose some algorithm how you can use NIRS-IVUS to guide calcified lesion treatment. So first, if you go with the pullback, check whether you have a calcification nodule. If you have it, you may distinguish whether it's with lipids or without it. If it is with lipids, you may try the just non-compliant balloon. If it fails, then go for the lithotripsy. If it's without lipids, and just do right away rotablation or orbital atherectomy, because there is no way that you can modify this calcification nodule just with balloons. If you don't have it, test whether you have a heavy calcified lesion modified by the lipid arc. If it's not heavy calcified, just go with NC balloon. If it is, try intravascular lithotripsy straight ahead. So this is algorithm which I propose that you can use to guide calcified lesion for the NIRS-IVUS procedures. Thank you very much.
Thank you, Thomas, for this great presentation about NIRS with calcification. Dr. Ahmed, have you used NIRS to assess calcium with calcified lesions in your center?
Yes, absolutely. The quality of image of the IVUS, apart from the NIRS part of technology, being used as an IVUS, grayscale IVUS, is very beneficial in detection of calcium and extension, and help you to see the nodules, because the quality of the image is best in class as a grayscale IVUS. If you add to this also the near-infrared spectroscopy and the chemogram that you get and the amount of lipids, then applying this very beneficial algorithm to deal with the nodules and with the other types of calcification is indispensable.
I agree. We've noticed the same thing. We've been using it in our center, and I agree the image quality is superior to other modalities that we've been using. Mohammed, what do you think about in terms of stenting for vulnerable plaque landing zones and trying to avoid the vulnerable plaque? What do you think about this technology?
Yeah, I think it's very helpful because sometimes the plaque burden might be low and it looks good by IVUS that it's a good landing zone, for example, in diffuse disease. So you probably with the NIRS technology, you can even cover areas that have high lipid core burden. So you can, for example, if you choose a stent that is 16, but at the edge there's a high lipid core, then you probably want to cover that, so you will end up choosing a longer stent, for example.
Yeah.
Actually,
go ahead.
Yeah, actually, there are some studies and some data that shows that if you end up with a stent edge at an area where the lipid core burden index is very high, you might either end up with a stent edge dissection or even an event down the road. So, and the same for in-stent restenosis. If you stent with an area a very high lipid core, this is more liable to restenosis than areas with lipid lowering. So this might drive you for better plaque preparation before putting the stent or the DCB.
Yeah, I agree. So it will help you with your landing zones for stenting. Any questions from the audience in terms of calcification or where to land?
So I appreciated the talk of Dr. Rodeler and his new algorithm that modifies the arc of calcium based on presence or absence of lipids. However, I must say the algorithm that we use that are based on studies from St. Francis, from Columbia University with Kiko Mahera, is a large validation study behind showing that the arc of calcium is the main driver of incomplete expansion below 70% of the reference area. Before proposing a new algorithm, I believe you need real data to confirm it. Maybe a final point, as you know, the newer algorithm proposed by the group is not anymore a rule of 5, but is a rule of 3. So 3 quadrants of calcium, length of 0.3 millimeter, and thickness OCT-based of 0.3 micron.
Okay. I totally agree that we have to run the new data, but this idea to deal with calcified lesion with NIRS, it's something which popped up just recently. I'm at the moment of analyzing in the core lab the plaques, how you can modify it, and how also you can distinguish between 2 different features of the calcification nodule, because it pop-ups that those are 2 different lesions. Because if you have a heavy calcified lesion with calcification nodule, you have to modify it, otherwise the stent may crack on it. If you have a soft calcification nodule, we've noticed that it's very easy to modify and you don't have to use those advanced techniques always. If you use advanced techniques on the lipid-rich plaques, you may expect more distal embolization. That's why I think it's important to distinguish between those 2 features.
If I may, on that, I completely agree. An eruptive nodule, then most of the times is a complex plaque with a fairly large lipid component, often eccentric. Better not to use rotational atherectomy, but going with a more conventional technique, and normally just plain balloons will do the job.
Yeah, that's true.
Go ahead.
What we saw with the case, a wonderful case presented by Dr. Ahmed, there was some dichotomy of the opinion. So my question is, if you get this type of the data in which LCBI is more than 400 and the plaque burden is around 70%, in which case you will like to put the patient on the medical therapy today with intensive medical therapy, and which case you will like to put do the intervention immediately on the table. Are there still something more deeper than these values, number one? And number two, if you have decided to put in a stent over there, do you put the regular stents which are available on the shelf, like the Synergy or the Zions or XYZ, or you decide to put some special stent, especially in these cases?
I'll leave the answer to Dr. Ahmed. Go ahead.
Yeah, actually, this is a very controversial point because we lack data that drive us to one way versus the other. On one arm, the PREVENT study that advised sealing vulnerable plaques with the stents have some critics that if you look to the details of the study, the LDL value, the mean LDL value for the patients that have been stented is more than 100. And this is, of course, needs optimization before doing this. On the other hand, you have some observational studies, and including the case that I did, despite the fact that the patient has a very well-controlled LDL down to the with the guideline-directed medical therapy, you still can have some events. So actually, there is no data at the meantime that I can answer if we go for that. Of course, we need some randomized data for this particular point, and a tool like the near-infrared spectroscopy will help us to go either ways. Regarding the second point of choosing the stent, this will depend on the lesion and the preparation and the characteristics after preparing the lesions. So I only choose which kind of therapy, either drug-eluting balloon or stent, and which type of stent after preparing very good preparation of the lesion, and then accordingly you can decide which strategy you go for. So it's not a device, it's a strategy that you can apply after preparation.
So there is a small comment. In your patient, like the LDL cholesterol was 1.47 or 1.5 millimoles. So whatever the data is available or is in the guidelines, it is in relation at the most with the secondary prevention. So extrapolating that data for the patient who is having a vulnerable plaque of this degree, is it appropriate, or do we need to use some other sketchy data which is available for the regression of the plaque, where you necessarily reduce the LDL cholesterol below 1 millimole per liter, and at the same time simultaneously take into account whether the triglycerides levels are also elevated, like in this morbidly obese patient or not, and do the therapy for that.
But I also believe in this case, the patient was diabetic.
Yep.
So it was also a highly vulnerable patient. So if you add the clinical features plus the plaque which you deal with, that might be predictor of whether you stented or not, treated or not. I think we have to take all the pictures, not just the lesion, because data from the PROSPECT trial shows that if you have a vulnerable plaque in the whole population detected, you have a small events. But if you just focus on diabetic patients, the events rose, and maybe that's the group which you have to focus more and apply different treatment than to the standard patients.
And I think we have also data from Prospect 2 study looking at specifically what you mentioned, the plaque burden of being more than 70%. If you have plaque burden more than 70%, high lipid core, they really do very bad compared to the patients who have lower plaque burden, let's say. But so the higher the plaque burden, the higher the lipid core. Of course, all of that will translate into events. And actually, in that study, bioresorbable stents, the patients who underwent and had bioresorbable stents did better in terms of MACE over time.
Great. Thank you, Dr. Mohammed. Go ahead and present your third case.
So my case is actually a follow-up case. It was a live case that I've done in 2023 for GulfPCR. So we'll look into the outcome of that case. I would like to know also how to approach that case from the audience. All right, I think I have, I will choose, okay. I guess I'm good. So in this case, we integrated, I guess, from the title, physiology and IVUS NIRS for the PCI. So these are my conflicts of interest. So just before diving deep into the case, I think the data about NIRS started from this pivotal trial, the LRP study that was conducted by Waxman and his group. They looked into non-culprit lesions in patients presented with acute, most of them acute coronary syndrome, around 1,500 patients. And then they defined based on NIRS data and the cutoff they use here for LCBI index of 400. In certain studies, you see 340 and other studies 400. But now I think we are using the 400 as a defined cutoff for high vulnerable plaque. So they looked at MACE, which is revascularization, MI, death, per patient level data and per lesion data. And what they found is over 732 days that MACE is higher in patients who have vulnerable plaques, about 13% compared to 6% in patients with non-vulnerable plaques. And per plaque level data, you can see the same thing, trend of higher events with vulnerable plaques compared to non-vulnerable. So I think that's kind of led the way for NIRS and FDA approval as well. So this is our patient that I told you about. The case was done 2 years ago. Patient is 60-year-old, hypertensive, non-diabetic, smoker. He presented with 30 minutes of duration of chest pain with inferior ST elevation, and that was his right. That was his culprit lesion, so we treated both the distal and the mid-RCA with IVUS-guided drug-eluting stents, size of, I think at that time, 4. Then there, you can see that's the diag and LAD. There is mild disease in the proximal LAD, but there is a tandem lesion at the bifurcation site in the LAD and then distal LAD as well. Definitely more than 50-60% stenosis, the same thing with the diagonal branch. So I guess I will stop at this stage. How would you deal with this non-culprit lesion? Maybe we'll start with the panelists and even with the audience.
Thank you, Mohammed. So this is a person that presented with an inferior STEMI and now has a lesion in the LAD and diagonal. Are you going to go for complete revascularization based on angiogram, or are you going to do something more? I think that was the aim of the study. Thomas, what do you think?
At first, I would check the physiology behind those two lesions, and then decide what to do further.
Yeah, I echo the same. And if we are going to, if we find any positive results from the physiology, then imaging would be helpful to delineate the vulnerability as well.
Anyone from the audience wants to contribute? Would you do any physiology or go ahead and stent it? It looks significant to my eye. My practice actually would be, I wouldn't do physiology. There's, I think in the complete trial, no physiology was done, and they went ahead and stented this lesions whenever they thought it was significant. I think there is some CT data also showing that patients with STEMI is a different population. They're more likely to have vulnerable plaque. So who in the audience would do physiological testing, and who would do direct stenting or go ahead with stenting? Let's show a show of hands. Who would do? Who would proceed with stenting?
I guess we can ask per lesion. Who would stent the LAD right away? Okay. Who would use physiology? Okay. And what about the diagonal? Who would directly stent it? Okay. Who would use physiology? Who would leave the diagonal? Okay. Who would leave the LAD? Oh, okay. So we have a few also for medical therapy. All right. So all good questions. So the task that I was assigned is to present a non-culprit lesions, intervention, and the role of physiology of those non-culprits. So we did physiology in this case, and we did physiology for both lesions. At that time, we just got the NIRS technology as well with the IVUS. It gives you a very nice picture. So this is what you get from IVUS NIRS. You get in the screen IVUS on the left side, high definition IVUS, and you get the chemograms that defines, as Thomas mentioned, the lipid core burden across each lesions or across the length of diagonal vessel, LAD vessel here. So here, for example, this is the distal lesion. Okay, we mark it here. So the max LCBI is 291. So not per the definition of vulnerable plaque, it's not vulnerable based on the content of the lipid core. And this is at the bifurcation. It's lesion as well. It's the max LCBI is low at this stage. Here you can see the diagonal bifurcation. This is a longitudinal axis across the LAD, and here's the proximal and distal LAD. So this is just to summarize the findings. The proximal LAD area was 8.5 millimeters square with plaque burden of 44. Probably it's hard to read, so I'm going to summarize. Here's 3.6 millimeters square minimal luminal area with a plaque burden of 51%. And this distal lesion, the plaque burden is only 54% with a 2.8 millimeter square area, and distal landing zone was about 3.5 millimeter square. We did FFR and IFR. IFR was 0.92. And in fact, the audience were, 2 years ago, were not convinced that the adenosine that we're giving intracoronary was causing hyperemia. So we went ahead, we did infusion adenosine, and we got the same numbers, FFR of 0.9. And so it's negative by physiology. And by plaque vulnerability, it's non-vulnerable plaque. Okay. Who would still go ahead and stent the lesion? Okay, we have one. Who would leave it? Okay, we left it, because that was the objectives of the study, the session. So this is the diagonal branch. So this is, again, the IVUS NIRS assessment. This IVUS on the left side, NIRS on the right side. You can see that's the lesion that is the tightest here. And the max LCBI at this area was 441. And there are a little bit artifacts here, unfortunately, because of saline flush. But overall, we are interested in this region. So those blacks are artifacts. And here, we did IFR this lesion. We didn't do FFR because the IFR was convincing and it was low at 0.85. The minimal luminal area was 2.1 with plaque burden of 70, almost 75%. So with distal reference of 5.3. So by IVUS criteria, vulnerability, and physiology, this is a significant lesion. Who would stent it? Okay. Who would leave it? Some people were voting for medical therapy before. You will leave it. Okay. So we went ahead and stented the lesion. So we determined the length of the lesion. We covered the plaque, high vulnerable plaque and high lipid core areas. We used, the stent size, but we used the distal reference for the stent sizing. After stenting, the luminal area we got is 5.2. We pre-dilated the lesion. It's a little bit fibrotic as well, and despite the pre-dilatation, you have some eccentric expansion, but the area was okay. Even improved further with post-dilatation to 6.1 millimeters square, which is higher than the distal reference side. So this is our case. I think our case just define the role of technology, as I echo Dr. Ahmed's point of the importance of using as much tools to define valve plaque vulnerability and to determine future events based on plaque vulnerability and physiology. In this case, we use both physiology and plaque vulnerability using NIRS and IVUS technology to guide our stent decision. And also it helps us even define areas that are lipid-free to improve our stent implantation and stent sizing in terms of length. This patient has been following with me right now for 2 years, and he's free of MACE and doing very well. I actually did not do any additional imaging or angiogram afterward, and he's doing fine. Thank you.
Thank you, Mohammed, for the great presentation. I think we have some questions from the audience.
Yeah, we have 2 questions about DAB in diagonal. Why not DAB in diagonal DES?
I guess I wasn't a fan of DEB at that time.
Would you consider it right now?
Yeah, maybe. I think so. Yeah.
Okay.
What do you think, Thomas? Would you have done DEB for the diagonal, or would you have stented it?
I think it was not a very wide vessel, so we may use DEB here because we have a good data for small vessels for DEB here. And it was a soft plaque, and also the data from OCT shows that when you apply it in a soft plaque, you have a proper dissection, it heals very well, and you can achieve a very good result. So I think it may be a good option, but we still need more data for that.
What do you think, Dr. Ahmed? Would you have performed DEB, or would you have went for stenting?
Yes, I echo him because of the size of the vessel. So at that time, maybe the recent data that came for proximal lesions and de novo proximal lesions were there out yet. But to apply these and change the practice according to the results, it will take some time, I think. But for the diagonal, I would consider leaving nothing behind, and unless I had to.
Yeah, I agree with Mohammed. At that time, 2023, I wasn't a big believer in DEB. I've changed my mind after the recent trials, but this is the beauty of interventional cardiology. More data changes practice, and things improve in the cath lab. I think we've got more questions on the iPad.
It's also about DCB.
And if I may draw your attention to we had 2 cases. One case was a case with vulnerable plaque with negative physiology and non-occlusive plaque, and did have an event. And Muhammad's case is have a negative physiology as well, but not a vulnerable plaque, and then he's following very nicely. So we have, these are the sort of controversies and the mismatches that we face every day. And this might fit with our colleague inquiry about what to do with these cases. So very nice 2 examples of contradictions that we face every day, and ignites a lot of thoughts of how to approach these patients.
I agree. The more tools we have in the cath lab, the more questions we're going to ask, and these questions are going to develop more RCT data to guide better management for patients and better outcomes. So with this, I'd like to conclude the session. I think the technologies we have are the use of these technologies can improve our overall outcomes and to guide better PCI. So thank you for coming to our symposium, and have a nice day. Thank you.